Good afternoon, everybody. Welcome to Cord Connects. Um, my name is Moshe Weitzberg. I'm a member of the Cord Board of Directors. I'm joined by Dr. Marianne Howie, who is my partner in running Cord Connects. Our session today is going to be on COVID-19, and we are honored to have a team from University of Washington who was the first group in the United States to encounter COVID-19, and they will be discussing some of their experiences with us. I am going to turn the floor over to them to introduce themselves and to get us going.
I guess I'll start. I'm Fiona Gallagher. I'm the program director at the University of Washington, and also the Cord president. Thank you for having us.
My name is Janelle Badgelak. I'm a dual appointed faculty with emergency medicine and intensive care, and I'm part of the ECMO program.
Hi, I'm Tak Watase. I am the Associate Medical Director for Harborview Medical Center, one of the hospitals of University of Washington, and primarily focus on operations in the emergency department.
So as we understand it, we're going to be sort of hosting more of a question and answer so that we can try to help other people who are sort of also grappling with similar problems and structures as we might have been and are continuing to do. There's a question also about residents intubating.
Yes.
I think one of the lessons learned is we tried to protect our residents by only having faculty intubate patients who are high rule out. I think that's probably a lesson learned. TAC and Janelle and a number of our folks actually created a simulation session so that we could intubate in shrouds so that we'd be more comfortable doing it, which was a wonderful session, and highly recommend doing something like that. Had we known how many cases we would get so quickly, we would have opened that up to our residents, our more senior residents, I think much faster. We're now training them to do that in a simulated setting, but in opening it up to our residents as well.
And one other thing to add is that with all of this, you're thinking about your resources, which is making sure that you don't expose your staff, which is the most important thing because you will lose your workforce, but not using your PPE. So as quickly as you can, developing protocols and plans for reusing your PAPRs, the things that are not necessarily disposable, and for cleaning those. If you can do that early and operationalize that, then that also will have, I think, positive downstream effects for resident education, because that was another potential concern is are we going to run out of PPE if we are putting 2 doctors in the place of 1 for every time that we do a procedure, or like specifically an aerosolizing procedure. And also the potential risk to the people in the room if you we're trying to avoid BVM and aerosolization there. So first pass success is really important. But I agree that it doesn't need to eliminate your experienced senior residents. But I think that the way that you can balance all of those competing interests is if you have the ability to sterilize your PPE in between uses so that it's more sustainable to have more than 1 doctor that's there for the same job.
Right, and also I think it's not only for education, but it's good for patient care as well. For example, a couple of pretty complicated peri-arrest cases that we had did involve a second provider to be in there to either resuscitate the patient or to sedate the agitated hypoxic patient. And that cannot be done with a provider and attending trying to intubate and then manage all the medical care at the same time. So that's why we think that having a second provider in those kind of cases is really crucial. It probably will make this case definitely go much more smoother. And for that role, I think we are now saying that senior residents should be in the room with the attending to co-manage those cases, and if they're appropriately in PPE to intubate as well. So we are having training sessions for them to intubate under a PAPR pretty much.
TAC, there's also a question out here about sort of our PPE situation and how do we keep residents, and I would extend that to faculty comfortable with reducing PPE supplies. It's been a high tension issue, I think, everywhere, and certainly no less so here.
Yeah, so I think there's no perfect answer for that. As we all know, it depends on what resources we have, what the engineering of the room is. I think there's a lot of factors that weigh into it, and also how we interpret the data as well. Obviously, we want to do something that will be safe for the staff and for the patients, but also balancing that with the scarce resources we have. And there were times when we were having, we only had like 2 to 3 days of the gowns left at one time, which is kind of scary when you think about that's one of the crucial things that we need. So I think there's a fine balance, and I think it pretty much has changed very dynamically over the past even week and even over a day, I would say. So I can't talk for every institution, but right now, as Janelle mentioned, we reuse the PAPR. We do have a process to reuse the N95 mask if we need to or would like to. And also, we just came out with a process where we could keep our goggles and our masks, use it for the shift. So but again, this might change tomorrow or today. But it is a very, I would say, difficult question to answer without any perfect answers, I would say, solutions.
And one thing that seems to be related to that is I notice working in the ICU and in the emergency department is understanding, like you said, the physical structure of the space that you're working on will really dictate how you use your PPE. And whether or not you're using an entire negative airflow area or a hot zone that you need to don and doff at entrance to that, and you move between patients, but then being mindful that you're not a disease vector moving between patients, because of course all of your patients with respiratory symptoms don't necessarily have COVID, so you don't want to spread it across multiple patients. So sorting out how is it best for you if you have a red zone for you to be conservative with PPE, limited PPE supplies, while maintaining the safety of your patients as you move between them. And then also understanding how the structure of the space that you're working in will differ in where you don and doff. So if you actually have private rooms in your emergency department versus if you don't, if rooms are separated by curtains, and then if you have a room and whether or not it is negative airflow or not, and whether or not you're actually able to convert rooms into negative airflow, as we've done with a lot of the ICU rooms, and some emergency department structures can do that too, where you can rapidly convert regular private rooms into negative airflow. So every structure is going to be really different, but thinking about how the physical structure affects how you use your PPE and how you can be really thoughtful in advance about conserving your PPE and not waiting to be near running out.
Okay, so the next question is about healthcare providers who actually test positive for COVID and are symptomatic. How soon are you allowing them to return to work? Do you require negative swabs? Is it based on number of days? What are you doing?
I don't think we
So our requirement is 72 hours after being asymptomatic. So if you test positive for COVID, you then, once you're asymptomatic, the clock goes on and then you can return to work 72 hours after being fully asymptomatic.
And they also had discussed that it was either that or 7 days or whatever was longer. I don't know if it is.
I think the problem is usually by the time somebody decides to get tested, depending on how many shifts they have and how much whatever their symptoms are, especially if they're mild. Sometimes people have been symptomatic, and we're trying to really encourage people to call out early with symptoms.
So Fiona, I saw you responded to this in the chat box itself, but perhaps for the group who's listening, the question was, many places have instituted respiratory care units or units for COVID patients. Did you take volunteers to work in this area, or expect that all residents would be eligible to work in this type of area?
So with the exception of the pregnant residents and any resident who has an immunocompromised medical issue, we expect all of our senior residents or EM2s, and we will possibly have some IM2s as well, but basically more senior level residents working in the respiratory area. And it is expected to be part of the job, similar to the expectation is the same for our attendings. So we expect our residents to really kind of follow along with the attendings. And so whatever we expect our attendings to do, we're doing the same thing for our residents.
And I just want to add a little bit more to that. So as Dr. Hayes mentioned, many places have instituted like a cohorted area for COVID patients or COVID PUI patients. And I think that's a very important thing. One of the things to consider when you do that is, so that area could be a very high stress area. And in some institutions, they might be wearing like a bunny suit PPE. And that is something which might be great for protection, but at the same time, it's a very high stress area. And if you're in a bunny suit, you're not going to be able to go to the restroom, for example, when you're in that suit. So I think when you're in a very kind of COVID dense area with pretty extensive PPE, I think you really have to limit the hours a person could work there. So that goes the same for the attending, the residents, the nurses. And you almost have to double staff that area, because if you're going to switch at 4 hours, you're going to need somebody else that's going to be coming in to work the next 4 hours. So I think that's one thing in terms of you have to consider when you're staffing. And I think that will really depend on what your surge plan will look like as well. So I think just staffing when you're going into a very highly populated COVID area wearing kind of a bunny suit, I think that brings a lot of staffing headaches, I would say.
I do want to say that it's been amazing just to build on, TAC and the operations team have really thought very thoughtfully about how the impact to the providers in the area, so that the resident and the attending have swap out so that you're only in that area for a certain period of time, so that you can also eat, go to the bathroom, do some other, and breathe. So, I have to say that the thought about the stress on the provider and on the physicians and the rest of the staff has been really, really thoughtful. And I'm really very impressed to it's very nice to be able to know that you'll be there for a short period of time. So those bodily needs will get taken care of.
Okay. Janelle, I believe you mentioned that you run the ECMO unit in your area, in your hospital. Can you give us an idea of how that was implemented here, and if you had face some difficult situations, such as which patients were going to get this resource when it may have been a lot of patients coming in and perhaps not the ability to provide it to everyone?
Yeah, so I'm part of the ECMO leadership team for the University of Washington, and you bring up a really important discussion point that I think is really challenging for many different areas of care and topics, and I've been thinking a lot about it with ECMO, of course. And whenever something becomes more finite, it becomes even more apparent how important it is to think about utilization of that resource. And so it's also important to think about the importance of maintaining the standard of care for as long as you possibly can. And then building contingency plans to maybe change the way that you traditionally deliver that standard of care, so that you're able to defend it. What I mean by that is deliver care in the way that you already would, provide an ICU bed for everyone who needs an ICU bed, evaluate every patient in the ER who needs to be evaluated, and just doing it in a different way that allows you to handle the surge in the number of patients you need to care for. So that would mean, increasing the providers in your hardest hit areas like emergency medicine and intensive care, and increasing the physical footprint and reorganizing the physical footprint in which you care for those patients. It can be tempting to think ahead to what's going to happen when you will be overwhelmed, but you don't really know if and when that's going to happen. And it's going to happen to different hospitals, potentially in different acceleration outbreak near one hospital, they may become completely overwhelmed, where a hospital a couple miles away is actually functioning at a fairly similar volume and pace as they had before. So it's important not to engage in premature rationing, where you would say, here's a patient who is maybe older with multiple comorbidities. I'm going to avoid doing what I would have normally done for that patient. If you already have the resources to do that. For example, intubate that patient if that's consistent with what they need for their medical care and consistent with their goals of care, if you have the resources available, and then continually working to expand your contingency plans as you move through different tiers of your contingency plans as you accommodate the surge. It's important not to move into something called crisis standards of care until you actually have determined that your hospital system, and region have collectively entered into crisis standards of care. And what that means is that now you are forced to allocate scarce resources based on the patients that are most likely to benefit from them. So I think that that's something that we really struggle with in emergency medicine and critical care, is thinking about what's going to come next, but it's really impossible to predict that. And it's really important that we maintain practicing the same way that we would normally do it. Don't prematurely ration, even though it can be tempting because you're afraid of what's going to come. And then and keep reassessing every 12 to 24 hours. How is your hospital system handling it? How can you surge to accommodate more?
To that same point, though, I will say that at the University of Washington, where we have a strong relationship with Seattle Cancer Care Alliance, and we have a number of patients who have late-stage cancers, we've actually, our palliative care colleagues have really stepped up to try to make themselves more available to have goals of care conversations. It's not about rationing. It's just about trying to make sure that we are, that we have actually people who can focus on those conversations for the rule out COVID respiratory patients who also have what's known to be a terminal cancer. It's really helpful to have somebody who can really focus and sit down with them to talk about their goals of care while we sort of prepare for the potential intubation, so that we actually are most consistent with what their goals are. So I would say that there are opportunities to not ration and not prematurely go into crisis management, but it's been actually really nice to have some of these opportunities to provide some of the best care to some of these patients as part of sort of their people stepping up and recognizing that we want to make sure that we are continuing to have those conversations and having people who are available to do that.
And I think that you bring up a good point, that the way that we, even though we are trying to defend the standard of care for as long as we can, there will be certain adjustments that are necessary in a COVID era, right? So for example, the time it takes to properly don and doff PPE will mean some appropriate delays to emergent interventions, when we just have to make sure that we are always putting healthcare worker safety safe, so that we can first, so that we can maintain the workforce. But other things, like for example with ECMO, our criteria for initiation of ECMO are much more narrow than they were pre-COVID. And then we see that though with some other things, like when we talk about goals of care with our patients, we need to make sure we understand that all of the interventions that we're offering for a patient, that we're thinking about it in terms of the justice of applying that scarce resource to as many people to do the most good as possible, and making sure that if we are doing something that is maybe in the column of heroic, that we truly think that it's something that the patient is really likely to benefit from.
Thank you. Next question is, what type of precautions are you taking to protect your families from you? I think meaning to prevent you from bringing something home to your family members.
So I could start off. I think everybody's different. There's no set rules that we have within our department. I think, but this has been a discussion in one of our faculty meetings, and obviously I think everybody's pretty much changing after their shift into their clothes that they came in, or just changing to a new scrubs before they go home, in order to not be the fomite, at least on the scrubs. And I do hear that a lot of people are actually kind of showering once they get home as well. Whether or not they are exposed or not, I think that's probably the safe thing to do. And also probably emotionally, I think that probably better as well. So I think those are the two main things I've been hearing from the faculty.
I know that we're tucking our socks, the bottom of our scrubs into our socks to try to make sure that we don't have any. The bottom of our scrubs are not touching the floor. I think the same thing that a lot of people are basically leaving their shoes outside. Basically getting naked in front of the house instead of inside the house, or changing at work and putting on clean scrubs before going home has been a strategy for a lot of people. But it's also led to some scrub shortages. So, so there would been a plea to not hoard scrubs. We don't have a very specific, as TAC mentions, that that everybody is doing. But I brought my mother-in-law home to do an elective hip replacement surgery, so I'm especially concerned about it, given that she's in her late 70s. So, we think about it, and I think everybody has different situations, but there's a certain amount of anxiety, and I think people are trying to be really, really careful. Janelle, do you have any thoughts?
That's the same. You guys cover the same things that we've been thinking of. And I live with another emergency medicine physician, so.
Please be careful. Okay. There's another question that says, I know the thought is that non-invasive ventilation is a definite no-no due to aerosolizing concerns. However, some of my reading indicates it's been used with success in places with appropriate precautions. Have you utilized it at all?
I might be able to chime in with that one. So this is something that we've been struggling with, of sorting out the risks and benefits of. So this is another good example of maybe how clinical care is changing in COVID era versus pre-COVID era, and trying to balance different the risks and benefits to the patient and the harms to the provider potentially and other patients. And this idea of aerosolizing procedures. So this is. Unfortunately, what part of the problem with all of this is that we're operating in an evidence-free zone. But our current recommendation is that in general, flu pneumonitis or pneumonia is really not in general treated very well with non-invasive positive pressure. And the adjunct for O2 delivery that seems to be probably the better device for this disease would be heated high flow nasal cannula. And then of course be worried about maybe aerosolizing with high flows, and had been really relying more on non-rebreather with the 15 liters per minute. But we just, as an institution, sort of collectively decided that perhaps maybe lower flow, high flow, limiting it up to like 30 liters per minute. And if a patient stabilizes out and looks great, maybe we can avoid intubation for that person, especially the younger people with a higher work of breathing that plateaus and does not get worse, then they can avoid intubation. But if they're starting to desaturate with higher FiO2s above maybe 70%, 60% to move towards intubation. And I can tell you, intubating these patients, that many of them will be on ambient air and then 12 hours later desaturating on a non-rebreather. And so watching them really closely, and if they're really not plateauing, with some kind of adjunctive O2 delivery device to be ready to move towards intubation, so that you're not struggling with a patient who's desaturating. You're trying to, from personal experience, get into the room as quickly as you can and safely intubate the patient. And so it is a judgment call. We need to be mindful of our resources, but again, trying to not have the crash intubation. But I think that, avoiding non-invasive is an easier decision for me. I don't think it's the right device for ARDS. Where it becomes more difficult is if you have a patient with, where we do have data to suggest that it improves mortality, is a COPD exacerbation, maybe the asthma exacerbation, and the heart failure exacerbation, or the patients who rely on it for obstructive sleep apnea, or obesity hypoventilation syndrome, or neuromuscular disorders. So that's really a tricky situation, and we've decided to use it potentially in some of these select populations, also sort of just depending on how much we think COVID may or may not be playing a role in their illness, especially the patients under investigation who are not proven to be COVID positive.
Thank you. Another very important question. Are there any special policies or operations that you have enacted when coding COVID positive or PUI patients, and what are the residents' involvement and reception to this?
I will defer to TAC, but we haven't really instituted any specific policies outside of just being in protection. Similar to that idea of being in crisis management, we are treating every patient the same and trying to give them the same care by and large to the best of our ability. Um, but I will defer if TAC has any other thoughts.
Yeah, and I might defer to Janelle. Sorry, Janelle. But one of the things that comes up is the fact that these people who have COVID, if they're coding, their prognosis is not going to be that great. So it does make sense in a way to limit the use of your resources. But at the same time, in the emergency department, I think it's very hard to say that a person has COVID or not. If a patient that has confirmed COVID comes into the ED and is coding, I think there might be a conversation of early termination. But for most of the cases that we're coding in the emergency department, we don't know at that point. So what usually happens is that we usually go pretty much all the way for these codes usually, even for PUI patients, because we can't see for sure that these are COVID patients. But for COVID positive patients, I think this might be more the scenario in the ICU. It might be a different story, and I might ask Janelle to kind of tell her side of the story.
Yeah, I think I completely agree that once you have a patient who has COVID and then is critically ill due to that, and then if their heart were to stop, the likelihood that CPR is going to be a helpful therapy for them to have a meaningful outcome is exceedingly low. And so if the patient is truly very critically ill with ARDS or refractory septic shock, CPR really isn't a therapy that is really going to help your patient. And so I think thinking about when you have a patient who becomes critically ill like that, then co-discussions are important. And there is a nice document that our palliative care and ethics team went through that's on our shared public drive that I also included in the chat, that kind of goes through a lot of the thought process, the outcomes, and some of the helpful phraseology as you talk with your families about this, because it probably doesn't make sense to offer an intervention that you don't think is going to improve your patient's outcome. And on top of that, now is going to put your providers potentially at risk of PPE breach. Granted, that's for patients that we have gotten to know for a couple of hours or days, which is different than the completely unknown patient coming from the field. Although I do think it's important with unknown patients from the field, especially patients that are critically ill, to treat them as if they are a PUI to protect your healthcare workers, because you just don't really know why they became that sick.
So this is a related question. Can you comment on extubation results and expectations for COVID patients?
Oh, like our survivability?
Your extubation rate, yeah. Like if the patient says likely you might have come off the ventilator, what conversation do you have with them?
I think that's hard. I could start with talking about that our mortality is quite high and we're looking at Chinese data that was one of the earlier publications that that was survivability. There was single digits of patients for all of them who were mechanically ventilated and ECMO. We have patients who are extubating successfully, even patients who are elderly. And so we do know the mortality rate is high, but it's hard to know what it actually is. And I think it's also really important to stress that looking at mortality is important to interpret it in the hospital system and the stresses that hospital system is seeing. Because if you have a hospital system that's operated at crisis standards of care, you're going to have a lot of collateral damage in patients who are dying who otherwise wouldn't be dying if you had the space, staff, and stuff to be able to care for them. But if you have an institution that's able to defend that standard of care, then we're just looking at the true mortality of the disease for patients who end up intubated. And that's So when you look at the data and you're trying to counsel your patients, it's really going to depend on what the capabilities of your institution currently are. So I don't think that we're able to quite comment on that just yet in Washington.
Okay, I want to say a tremendous thank you to our speakers today. Thank you for taking of your time during this busy pandemic and sharing your experiences with us. A tremendous thank you to all our participants. We hope this was very useful for you. Our next Cord Connects is scheduled for April 23rd. Keep your eye on your emails. And to all of you, please be safe, please be healthy, please be careful as you're taking care of patients. This is difficult for everyone, and as for us as emergency medicine providers on the front lines of this, this is difficult, but I want you all to remember the importance of the job that you're doing. You are the heroes of this outbreak, and without you, we would be in serious trouble. So thank you for being there. Thank you for doing what you do. You are amazing, and please, everybody, be safe and healthy throughout this.
Thank you so much.
Thank you
Thanks
guys.
for having
Have a great
us.
day.
Thank you very much.